So again, I'm Clare Larkin, Minnesota Department of Health Oral Health Program, and part of my work also involves working on a HRSA contract with Normandale Community College, and I just want to put in a plug again to make sure that you visit the tables in the back. I'm going to be talking for a few seconds here about school-based dental sealant programs, and the table back there for Normandale has a fact sheet on what are we really talking about when we're talking about collaborative practice dental hygienists. So please visit the sponsors in the back room. I am just almost speechless following Brittany's presentation. We got to spend time with her last night, and she and I spent 45 minutes in the car this morning just yakking. I feel like I've known her for my whole life, but what I envisioned for this section is that a large part of my work that I will miss when I retire has been working to advocate for school dental sealant programs. It's one little piece of a big pie, and I really love, I took some of Brittany's comments that to move oral health where it is not. And when we talk about school dental sealant programs, that is one area that certain locations do have school sealant programs. Many schools in our state do not. And our vision at the Department of Health Oral Health Program is to work toward a coordinated knowledge base and a coordinated model to really have Minnesota be finding out so that one day we can be having graphs and charts up on the screen to know what the state of school health is here in Minnesota. And we do not have that. Massachusetts, I know, does a really fabulous job with that, and we're getting there, which is why we're bringing these wonderful people together. So on page 5 of your handout, you will see that we have 3 presentations, and the vision for this was, again, to bring together persons who represent organizations that are not strictly clinical or oral health per se noted as strictly oral health. We have Dr. Julie Philbrook, and her bio is on page 5, and we welcome Julie. Julie's a great friend of Nancy Frank Wilson's. We have Leah Berg, who I've gotten to know just recently. Leah is a community health specialist for Washington County, and Leah is now getting involved with some oral health collaborative work too, so she's learning about oral health. And Dr. Brittany, of course, you all heard her bio and her great work. So what I want you to think about during their presentations is, I'm stealing again from Brittany, a comment about, I'm a dental hygienist, I learned clinical education, I learned the biomedical model. And what my vision for the panel was for them to talk about not doing the biomedical model that in my mind is clinicians doing things to people, but oral health folks doing things with people. And these folks are going to talk about that community, about that neighborhood, which is the front cover of your handout. Thinking of oral health in a neighborhood. And again, with the work that I do around school dental sealant programs, infusing that into the schools to have the schools be that neighborhood. So let's start with Julie. We're going to move quickly. Sadly, I will mention that Brittany needs to catch a flight, so you'll have to do some communicating with her offline. She won't be able to stay with us through lunch. I don't believe that hasn't changed, right, Brittany? Right, so she will need to be heading back to Boston. So I'm going to just say probably you'd be open to communicating, email Brittany. So let's start with Julie.
Well, thank you. Yes, and Nancy and I worked together on a variety of things, and when she was telling me about this workshop, and then she goes, I want you to present. I'm like, I don't work in this area. But the more I looked at it is we all have the common goal, and that is to prevent illness, to prevent injuries, just have healthy, happy people in our society. And so looking back at the injury prevention programs that I work with, you're going to find very common things, and hopefully I'll be able to give you some tips and ideas on how to go back to your community and make a difference. As a nurse, I started working at Hennepin Healthcare. Of course, we have to get used to using that word, don't we? Hennepin County Medical Center. I've been there 35 years, so it'll always be that, but we're becoming more of a system. But I worked in our trauma critical care unit for 7 years, and it was challenging. I enjoyed it. I enjoyed, helping people get better, but then there were those that didn't. And I remember oftentimes standing at a bedside, taking care of a patient, and thinking in my head, if only you had done one thing different, you wouldn't be here today. If only you'd worn that seatbelt, if only you had slowed down, if only you made different choices of people that you associated with. So when I got the opportunity to go into the prevention world, as a trauma center, we're required to have injury prevention programs. So I took a big leap of faith, and 27 years I'm still doing it, so I guess it was a good leap. To say, maybe I can have some influence on the front end. And so that's what I want to talk to you a little bit about, and how we can attack some of these challenging things. One of the foundations for one of the first programs I worked with utilized this health belief model. And the health belief model is a psychological model that attempts to explain and predict health behaviors. This is done by focusing on the attitudes and beliefs of the individual. The model was first developed in the 1950s, and it was actually developed in response to the failure of a free tuberculosis health screening program. And since it's been used in all sorts of, whether it's injury prevention or health prevention, they've also used it in addressing the HIV and AIDS crisis. So it really crosses all prevention messaging. So, okay. So basically, it's based on the understanding that a person will take a health-related action, oral health, if that person, these three things need to be happening for your work to be fruitful. The person themselves have to feel that they have a negative health condition. First, we have to let them know that this isn't normal. This isn't something you should accept. There's things you can do to make a difference. That they have a positive expectation that taking the recommended action, that they can avoid the negative health condition, so that they are empowered to say, you can take a step and you can make a difference for yourself. And the big key is that they feel that they can, if they can successfully take the recommended action. So that we are giving them the tools. So not only do we say, that your oral health is important, this is why I care about it, you can do something about it, but that we give them things that they can do to make a difference. So of course, with most theories, you've got a conceptual model, and so just a little bit on this to explain it. So these are things that you want to look at, areas that maybe you in your prevention efforts, in your community outreach efforts, want to focus on. You have the individual perceptions, the modifying factors, and then that big key, that likelihood of action. So of course, there's some things that we can't, change: age, sex, ethnicity. There's some of the things that are modifying or different for them might be their socioeconomics, and then their knowledge base. Have they been educated enough to know that there's a problem, they can do something about it? Then we have to also consider their individual perceptions and what they perceive it as an issue. I can't make you value something. I can't make you change. You have to see that that's something within you, and if we can give you the tools to get there, that's what we're trying to do. Also, that the modifying factors, if you move back over, you've got cues to action. Big thing, education. I mean, that, of course, that's our big thing, is we can get the information out there and enlighten them. Maybe it's the symptoms. The first interaction you have with them oftentimes is they come in because they're having a problem. There's that teachable moment. That might not be the time to address all the prevention, because you want to address their pain and other things, but you've established that connection, that relationship, and how can you take that to the next level when they're at a point where they're ready to learn? And then also working with the media, and now more than ever, we have that opportunity, and I know we're going to talk about that later today, is how do we work with the media? How can we get them to spread our message and help us get that out there, whether it's your traditional TV, radio, or of course the social media that we are so prevalent today. And then the likelihood of action. Again, we need to provide as much information as we can for them to look at and see the perceived benefits. What's in it for them if they make this change, if they're able to access the care that they need, versus the barriers. The first thing, I can't get there, I can't afford it, I mean, there's a lot of things, and some of them are very real, but we also know that we have a lot of systems in place that can overcome those barriers for them. So just letting them know they exist and try to help them to knock down those barriers. And the more we can identify not what we see as their barrier but what they do. We might think, well, that's not a barrier, but that's their perception. So that's where we need to focus. And then the big thing here is their likelihood to be willing to change. Again, I can't make somebody value something. I can't make somebody change, but I can hopefully put some of these pieces in play to get them there. And it might be a process. It's not going to happen the first time you have interaction, of course, or maybe several times down, but we just have to keep kind of chipping away at that iceberg. We talk about, that proverbial injury and illness iceberg, where we only know about the tip of the iceberg, but how can we keep chipping away at it? And you yourself also need to celebrate the small successes. I think sometimes we might have a grant, we might have a program, we have a year to get this out, and we didn't meet our goals, and we start to feel really defeated. But start to look at those small successes. I mean, Brittany, you just shared how, that one child changed so much for you, and how you kind of chipped away at the global health. I mean, you didn't go in and say, okay, UN, okay, somebody, we need to do this, and it happened. But not getting defeated, and also taking time to go, but we did do good things here. And then how can we take it to the next level? With the preventative framework that we work with, again, we come back to that self-efficacy. They have to be wanting to do it. We just need to hopefully give them the tools to knock down those barriers so that they can feel empowered to do it. And it's a cycle. What are the causes and the consequences? What can you do? What can they do to prevent it? How can they make it happen? What are your barriers? Ask them, what are your barriers? Use that word. That's something that's actually just new come into my vocabulary in prevention, is talk to people and ask what their barriers are, and then help them figure out how they're going to get over it. Don't offer them a simple fix. Help them process it. And of course that takes time, but that time invested on this end is going to be, of course, fruitful later on, and hopefully they start sharing that within their families, within their ethnic community, within the community as a whole, on how that can work. And they become your ambassadors. And then how can they maintain the change? They may come back 6 months later and you say, yep, 6 months later they're doing something, or they're taking better care, or things have slowed down in their oral disease problem. Yes, that was a success. But what are they going to do down the road when that grant-funded project isn't there, or there's budget cuts and things aren't happening? Setting up a system that isn't necessarily dependent on one service, but gives more of a global and community response, and getting the community to see it as well. So basically, to sum up, the health belief model suggests that a person's belief in a personal threat or illness or disease, together with the person's belief in the effectiveness of the recommended health behavior, so do they see it as something that's going to make a difference, their behavior or action will predict the likelihood of that person will adapt or change their own behavior. So I just wanted to introduce that to you. There's a lot on that out on the internet, a lot of examples of where this has been used, both, like I said, in the injury realm. We look at trying to get kids to wear helmets, getting kids in car seats, putting the rear-facing car seat in the back seat. 20 years ago, we just never thought we'd get there. Well, between legislation, education, and media, we hear a lot in the media, we have made huge stretches in that. We have a long way to go, but we celebrate those small successes along the way. And so I think this easily can be translated over into the work you're doing. So I just wanted to introduce that to you. We're going to have others from the panel, and then we'll have questions after. So thank you.
Thanks, Julie. My name is Leah Berg. I am a senior community health specialist with Washington County Public Health and Environment. If you're not familiar with where Washington County is located, it is the most eastern metro county bordering Wisconsin, and I work in Stillwater, but we serve communities as far north as Forest Lake and as far south as the border of Hastings. So I work on various public health initiatives in the department, but my primary role is working with the statewide health improvement partnership grant, or better known as the SHIP grant. So how many in the room have heard of the SHIP grant? Oh wow, quite a few. So I won't go into huge details about it, but I'm going to talk specifically about a lot of the initiatives that I have worked on in Washington County. And previous to my time at Washington County, I worked with Isanti County and Faribault, Martin, and Whatwan County. So I have very different perspective from rural counties to metro counties and our coalitions and collaboratives. A little bit of background from me, I have a master's degree in community health education, and when I was getting my master's degree, I was working at Faribault, Martin, Whatwan counties, and in grad school they kept talking about all these collaboratives and coalitions and work that you would be doing, and I'm kind of like, is that real? And then once you get into public health, you're like, yes, I have a collaborative and coalition and partnership meetings every day, and it's really fun work and it's really exciting. Living Healthy in Washington County is also Washington County specific SHIP initiative. So if I kind of say Living Healthy or SHIP, it means the same thing. Our mission is to inspire and support residents to live longer, healthier lives through actions that increase opportunities for physical activity, healthier food options, and decreasing tobacco use and exposure. So kind of what Julie was alluding to, our main goal is focusing on implementing policy systems and environmental changes that make sustainable change that are everlasting, that are things that can be implemented that don't require funding, making sure that an apartment complex goes tobacco-free and stays tobacco-free, but then is also offering those kind of supports to help residents who want to quit smoking. SHIP strategies involve multiple sectors, schools, communities, businesses. And one thing that I find at the local public health level, local public health is really unique in the sense that we have many different programs that intersect with the same organizations and sectors. So not only do I, as a community health specialist, communicate with schools on a regular basis, we also have nurses who talk with schools. We also have food inspectors who talk with the schools about food safety and food preparation. We have environmental health specialists who talk with schools about hazardous waste and waste consumption. So really what I do in my role is try to leverage those connections so that it's not 10 people from the county going to the school and saying, hey, guess what, I got another grant, what do you want to do? And talking with my colleagues and making sure that we're all on the same page and seeing where we can leverage those existing relationships. One of my main roles is working with businesses and working on worksite wellness. So implementing, like I said, the tobacco-free policy on a work site, or making sure that an employer has a supportive place for breastfeeding moms. So a few years ago, I sent out, I would say 200 mailings to businesses within Washington County saying, hey, guess what, everyone, I have this great funding opportunity, love to hear from you. These are the things that I can offer you. How many do you think that I got any responses? I didn't get one response. It was one of those things where you're like, I have this cute letterhead, I'm from the county, people will love it. And I was just like, no, I think I got like 5 that were returned that were saying, this person this business isn't even a business anymore. So that was kind of like, I sat there and thought, well, is this not how people are communicating anymore? Or how can I really meet businesses where they're at? And I have this great program. I want them to hear about it. And I'm so embedded in public health, so of course I'm like, I would love this if I worked at a different place. But I sat down and talked with some of my colleagues, and they're like, well, have you connected with the local chambers, or have you connected with so-and-so in our department actually meets with businesses and does grant recycling programs? And I was like, no, I haven't. So then I started meeting with the different chambers and places that businesses trust and already have an existing relationship. So getting on those types of programs really leveraged my relationship with businesses, because then when I met with the chambers and did my whole spiel about, hey, I have this great funding opportunity, I'm here to help, they were like, oh yeah, I got that letter, but it got thrown away, or it didn't get to the right person. A business, it could get to the receptionist, it could get to the CEO, but who's the person that is really going to be the most impactful at making those healthy changes in a work site? And you need to have someone with like the health belief model. They have to be ready to make those changes. If they get a letter in the mail saying, I have $5,000 to work on tobacco-free grounds, and they're like, our place is tobacco-free and we don't even have tobacco users yet, they don't even know, they might have some employees that are or need that assistance, they're not going to be willing to be open to that or wanting to even discuss those opportunities. So it's been I think my most success has been partnering with different organizations and leveraging like existing partnerships. In Washington County, we also have a school nurse collaborative. So a group of all the districts in the county have school nurses, and they meet on 3 times a year. So it's a great opportunity to, when we have school-based grants, to meet at that meeting and showcase the opportunities that we have, saying, hey, we have funding for physical activity in the schools. What do you think about that? And just getting their feedback and saying, hey, you should really connect with so-and-so at the district, and making it more of a friendly ask versus we've sent out letters, we've sent out emails, and it just doesn't seem to be working as much as those personal one-on-one collaborations. Recently, for the last couple years, I also work on the healthcare strategy of SHIP, and we have been trying to work on reducing tobacco cessation within the dental clinic setting. And it was kind of a new thing. We were like, I don't really know how to get into the dental clinics. Well, also at Washington County, every dental clinic produces hazardous waste. In my department, we are public health and environment, so we have environmental health specialists who go out to the dental clinics on a regular basis and inspect them. And I sat down with that individual and said, what are your inspections like? What do you ask? How are ways that we can partner together so that I'm not going to those same exact dental clinics as I'm Leah from the county again? And, she's like, actually, I am doing a dental audit, and we'll be sending this out soon to all dental clinics within Washington County. And I was like, oh my gosh, this is my opportunity. Can I add 3 questions about tobacco cessation? And I was able to add 3 questions to the dental audit and get responses. So I was like, oh, I actually got feedback this time. And out of 125 dental clinics, 20 responded saying, yes, I'd like more information. And again, it goes back to that health belief model. Those individuals are ready, and now I feel that I have the capacity to go into them and say, hey, you said you wanted this information. Now, how can I meet your needs? Is it more training opportunities? Is it you just want to refer patients to tobacco cessation resources? How can I actually help you? Versus me assuming that all the dental clinics in the state need tobacco cessation resources or are ready to make those changes for and promote that for their patients. Living Healthy in Washington County is championed by a community leadership team. So we have a community leadership team that meets on a monthly basis that is key stakeholders within the community. And that also is a really great opportunity for us to leverage our funding opportunities and say, hey, this is what we have going on with SHIP or with school-based Sealant programs, and getting those back into the community, because we have school district leads, we have healthcare professionals there, we have nonprofit organizational leads, we have city staff. So really, it's spread amongst the county to say, you know, these are all the opportunities that we have, and could you please share those resources? The most rewarding thing I think about my work is the collaborative efforts. And I will say it's not easy, and it hasn't been, and it's, you know, getting my questions on that dental audit took 3 years of being in the department and really learning and gaining those relationships and leveraging those existing partnerships. So I think it's always going to be we're always going to be trying to find the next thing in promoting health promotion, but it's a really fun and exciting journey.
And I'm going to have Julie come back up with just a couple slides that are going to be a nice supplement to what Leah just talked about, of creating those partnerships and opportunities to really share with your schools, share with your community leaders about how you can be intersecting each of your programs.
So as we were talking about this, it just kind of all falls into place really well. So I did a little looking, because I know one of our frustrations is, okay, the schools, captive audience, let's get to those kids, this is critical, this is important, and the schools go, yes, and we have a list this long of other things that are important, and we've got to cover, and the state says we have to cover, and how do you get them to see the benefits of bringing it in? Not that they don't see that it's important, but they've got a million things on their plate. And so I just want to share with you some thoughts about how you can do that. And as I was researching this, I Googled, you know, Google's my best friend, and put in there, you know, how can you connect businesses and schools and topics? And lo and behold, on the Department of Education's website is a toolkit. Does anybody know about this toolkit? Okay, I didn't either. So it's actually the Business School Partnership. And it is a forward on there from Governor Dayton. It's fully endorsed by the state for another week, I guess. But hopefully it'll continue. And again, this is pretty wordy, but I just wanted to introduce this to you, because when I went to the schools and said, you know, we got to get kids to buckle up, we got to get them to you know, do all this safety things. We brought in people with brain and spinal cord injuries, and the health classes loved it. And I was actually in the curriculum in the health classes. Every quarter I was going in and talking to all these students in their classroom, and it was wonderful. But bit by bit by bit, they had less and less and less time as more and more requirements were put on them for what they had to cover. And so had to get kind of creative with how we were going to address this. Not that they didn't value it, but they didn't have the time. And so what I started doing was I actually worked with my own daughter's school, and I encourage you to, if everybody in this room adopted one school, you know, and the school is like, oh, you're a parent or you're a grandparent in our community and you want to come and do this, and you start with one class, and again, chipping away at it. Here's an example. We wanted to do something with, there's a walk to school day, and it's a Safe Kids project, and we get a little grant, and I have to find a school to do it, and sometimes they're like, oh, we don't have time. But I'm like, well, how about if we do just one? You know, we'll have just the kids that are walking, and we'll, you know, we'll kind of encourage that. And over the years now, this last year we had 700 kids, not necessarily that could all walk to school, but we actually had them get off their buses further away, and they all got to walk to school even off the bus. So we had all these 700 kids walking, and then throughout the day, then the teachers signed up, and I could go in for 10 minutes at each class. On that day, I had a little roving cart, and I went from class to class to class and talked about how to do that and how to make it fun. And now what happened this year, they called me and said, when are we going to do the walk to school day? Whoa, okay, first I couldn't get in the door, now you're wanting me to come back, and you're giving more and more time, because all of a sudden they saw the value of it. So again, you know, chipping away at it slowly, but if you come in as a parent on the PTA or a parent in that group, whether you're a business or a business owner, or, you know, dentistry, or coming from public health, come in from that level, and they're more likely to do that. The other thing I encourage you to do is tap into the groups that are looking for projects. The National Honor Society, the Kiwanis Key Club, they have to do volunteer hours. They're looking for something to do. You come in and you kind of give them, hey, can you want to work with me on this? Now, not only are you getting in there, but the school listens to them. You know, the students say we want this. The student council says they want this. So maybe coming at it from a different end than the letters that don't get to the right person. It's very frustrating when you got this great thing and all this enthusiasm and it falls flat and you lose your, but again, start small. And so like I said, my very first one there is I always try to start with small successes and build on them. And they become your marketing. They're the ones who tell the other teachers, like, well, I want that in my class. How do I get that in my class when they talk at lunch hour? Where do you already have the connections? Like I said, the parent organizations, providing the opportunities. Hey, how can I help you meet what you need to do? The big thing there is creating a culture of mutual rewards. I have what I need to get done, and they have theirs. How can we marry those? How can we help each other meet those goals? And having them see you as a means to an end for themselves. Another way to talk about it, a little higher education level, high school, middle school, high school, is introducing them to careers in oral health. Hey, can I come in for a career day? Can I come and talk about, public health? Can I, have somebody come in and talk about that? And then you slip that prevention or that information in there as part of that career. This business partnership that they talk about literally is having kids actually come and see how a business is run. How is a dental office run? How are things done? So again, you're getting at them from kind of a different angle than to say, brush your teeth, floss your teeth, get your sealants, and then you get their trust as well. That's probably the big thing is the schools are like, if I give you the microphone, what are you going to say? And I've had that fall flat in talks. It's like I tell somebody what I want them to say and they go off on a tangent. Now how do I pull them back? But if you start to build those relationships and there's a trust level, they'll just give you the microphone and let you go. And then also challenging the students, come up with your messaging. What resonates with them? Poster contests. I did that. I got $20 Target gift cards, and all the kids, I gave them some messaging that they could do for the walk safety, and I had hundreds that put in. So they're going at home and they're talking about, I got to do this poster, I could win a gift card. It's a small success, but you get there and then you find out what messaging resonates with them, not what do we think with them. And so it kind of comes back to those health belief concepts. So I just want to tell you, if you go on Department of Education website and look for this business partnership, there's a whole tool guide on there, and we could probably put a link on the website or with the notes from this presentation to it. But it's really a nice guide and a good way to start.
So now we're going to have Brittany talk to us about her experience with social networking. And I will let her introduce this very fascinating subject. A lot of her work is about community water fluoridation, which of course the state of Minnesota has a lot vested in that preventive strategy as well. And as soon as Brittany is ready, I will let her take it away. We're going to try to be done, Brittany, by 11, and I know you have a lot of material to be presenting, so, okay, thank you. And Dr. Crespo, will you be able to let Brittany know about maybe 5 to 11? Oh, okay.
That's okay. Sorry.
Do you need me to?
No, I'll just, I'm going to talk from over here. Okay, so I'm going to transition a bit. You'll notice I have a couple other things now listed. I also do communications research with the Berkman Center for Internet and Society and MIT's Center on Civic Media. So just to bridge that from what I just talked about, the quickest example I can give is in today's world, there are more cell phones than working toilets. So it's not uncommon for a person to be connected on social apps like Facebook or WhatsApp and then to go home and not be able to use the toilet safely or get a clean drink of water. So understanding digital technologies and the role they play in my health communication work is how I've gotten into this area. So I'm going to do a couple things, and I'm going to power through because there is a lot that I could talk about. So I'm just going to kind of power through and give you an overview. We're going to talk about debunking. So they're talking about the great work that they're doing, and I'm going to talk about some of the challenges that digital communication and the internet provides for people doing health communication work. And so we see a lot of misinformation going on online. My cover slide called it the age of information disorder. And so, for example, YouTube and blogs are very trusted sources of information for people. Does anybody know how much new content is uploaded each minute to YouTube? Every minute. 100 hours of new content every minute. And how often do you think a new blog is created? It's estimated about every half second there's a new blog. And many of these are about health and health issues. And so considering the level of trust that people place in these sources, that's kind of where the term information disorder came from. We know a lot of times this information isn't entirely accurate, it's not evidence-based, it makes the work that you're doing more challenging, and we can't possibly keep track of all this. So instead of keeping track, we often find ourselves debunking or putting out corrective information, right? So I'm going to talk about that a bit. I'm going to talk about what's really going on online and how does the internet influence people's behaviors and their health belief models, for example. What's modifiable? So we've been doing the diagnosis stage, and then I'll briefly get to what can we do? What kind of treatment plan can we develop now that we know what the internet looks like, what it's doing? I'm going to start briefly with this article as just a case example of how kind of evidence and science can morph and actually cause some harm. And so this may look familiar to some of you. This is a study that came out several years ago. It's kind of been nicknamed the Harvard study, and it's kind of one of the studies that is linking fluoride to IQ. Does that ring a bell? Have you heard that topic come up? So this is one of the original studies that came out that kind of started that concern. And so at the time when this came out in 2014, one of the authors was affiliated with Harvard, so it kind of became nicknamed the Harvard study. And essentially they made a recommendation, so they made recommendations for several elements that they are recommending be classified as neurotoxins, and they recommended fluoride be classified. They made this recommendation because they had done a review on previously done studies, a handful, and had made this conclusion and recommendation. Now, they acknowledged that there were a lot of limitations, that many of these studies were done outside the US, they were done in areas where fluoride was naturally occurring in the water sources at very high levels, much higher than what we have in the US, and this was not related to community water fluoridation, and they acknowledged that in the study. But nonetheless, as soon as the study was released, within 24 hours, as you could imagine, there was a flurry of media coverage and bloggers sharing and spreading this article with the narrative that we're poisoning children's brains with our water in the US, right? Even though that's not what the message of the story was. And so this is a classic kind of case example of how these things can run away from us. So of course, many organizations have been debunking or putting out corrective information or clarifying information, acknowledging the limitations of the study, acknowledging that this wasn't about community water fluoridation and we can't make that leap, et cetera, et cetera. And yet this corrective information hasn't really had the impact that we would hope, right? We're still today managing this concern about fluoride and IQ. And so this is a fancy graph that basically says debunking can backfire, and that when we provide a person with corrective information, it actually makes them hold on to those beliefs harder. And so when we tell somebody that's concerned about this possible connection between fluoride and brain development, that's not right, they become more concerned, they hang on to that more. And so this is why we're starting to figure out that just putting out corrective information isn't actually what works. So then we started to think, well, what does work? What can we do then if we know just corrective information isn't enough? And this builds from the work that they're doing. And so I'm just going to go through a couple definitions of what we know now. So the first one is confirmation bias, and this is accepting only the information that conforms to our pre-existing beliefs. And so today on the internet, we can go and find almost anything that conforms to what we already believe, right? So we're starting with this concept called confirmation bias. And then it turns out it's not just misinformation. There's actually a lot of different categories, which means then we might want to tailor our responses based on which of these. So misinformation, false information is shared knowingly or unknowingly, and no harm's intended. It was just misinformation. Disinformation, false information, is knowingly shared, often intended to cause harm. And then there's even malinformation, which is true information is shared with the intent to cause harm. And this often is very personal information that someone might publish about another individual on the internet for all to know, for example. So we're figuring out that sometimes we're dealing with misinformation, sometimes we're dealing with disinformation, which is often why debunking doesn't work, because it's the intent, it's not the message, it's the intent behind the message. And then this leads us to filter bubbles, which is algorithmically derived content that we enjoy. So essentially, when we go online, there's so much information, we'll never get to see it all. So Google and Facebook, they have algorithms that respond to the way we behave on our computers and provide us with information that they think we're going to enjoy and that we're going to like. So we keep coming back and using their product, right? And this leads to filter bubbles, where we start getting exposed to only a specifically selected kind of content that often mirrors our own confirmation bias, and then we create echo chambers, which is selective exposure to information based on these confirmation biases. So we actually get limited to the kind of information that we end up seeing or reading. And I just want to add bot. So you may have heard this term bot, an automated programmer account that interacts with us. We used a bot to get here this morning on our phone, following directions. Has anyone ever asked Siri a question? Hey Siri, what day is it? I hate to tell you, Siri's not real. She's a bot, I know. But this just reinforces bots are everywhere. We literally interact with them hundreds of times a day and may not even recognize it. They can be very clever and very engaging. This is something to remind our patients and communities that there are limitations to the kind of information they can find themselves, and it may feel so personal and very important for them, but that we are the humans that understand them at a much more emotional level, and that's really where we need to start focusing. Okay, so let's do a quick little game. Misinformation, disinformation, or malinformation. So I'm gonna start. This is a map. This is what the internet looks like visually. Has anyone ever seen what the internet actually looks like? This is the work we do with MIT. We map out these information networks on a given topic. If you want to know more about this, this is a fluoridation information network. We published this in the the American Journal of Dental Public Health, or the Journal of Dental Public Health. So I can share this with you. But sorry, Journal of Public Health Dentistry. I should know my own citations. So this is what the information network looks like around water fluoridation. And so you can see a bunch of different colors, and these kind of represent echo chambers. So these are publishers who tend to link to one another because they share the same kind of sentiment, or they share the same kind of language around water fluoridation. And the bigger the circle is, the more links they're getting from others. So they have a lot of influence here. So this is where the Harvard study was published. This is the NIH website where they house scientific articles. And so this is the original study where it lives online. And here is the close-up of the blue color, which tends to have a focus on US policy and advocacy. So I pulled from a source from that network a direct quote. A team of Harvard and Chinese scientists published a study that warned of fluoride's potential to reduce human intelligence. They issued this warning after reviewing dozens of studies from the past 2 decades. So this is from directly from one of the sources of information in that kind of blue echo chamber. So do you think this would be misinformation, disinformation, malinformation? I think it could be considered either mis or dis. I would tend to lean toward disinformation because of that deliberate word choice, warning. So the publication was not a warning. It was, these are our findings, but there are limitations. The authors kind of did their due diligence. So that's acknowledged there. But then this, there's an anti-fluoride advocacy group who picked up, I'm going to skip that, who picked up this study and kind of changed the narrative. And so this is where it really becomes just as much about the messenger than the message itself. So they acknowledged this study was done, but they dropped the limitations. They didn't acknowledge what the study means in the broader body of literature around water fluoridation, which, as we know in research, is one of the really important things to do, is acknowledge a study's findings within that broader body and see how the evidence continues to emerge. But all that drops. It becomes about one study, and now we have to change everything because of this study. And so the narrative starts to become more about what the messenger's beliefs are than what the content of the message really is. And then we see that, so now let's talk about how does this kind of narrative start to spread? How does information, or disinformation in this case, spread? And so this is a major newspaper in Texas. There's a lot of challenges to community water fluoridation at the time we built this map going on in Texas, and so a major newspaper linked to this advocacy's website and continued to share and perpetuate that disinformation. So even though they're talking about a study, the narrative has changed. It's like that game of telephone. And then we see a small community in Texas linking to the newspaper, sharing that narrative and voting to eliminate community water fluoridation based on a single study. So these are the kinds of things that are really concerning, and why we really want to understand the differences between misinformation and disinformation, because it's really about the intent, and people might be more open to corrective information or debunking depending on the intents of these narratives. So that's just one example. And then one thing I want to share is that look what's happening. This particular narrative is kind of clustered within the map. This is starting to form an echo chamber where we're seeing this kind of similar narrative echoing around these sources back and forth among themselves, right? And it turns out we've done actually over 100 different case studies and mapped out on all kinds of different topics these online ecosystems. And every single time we see these echo chambers forming. We see all these different colors of communities forming based on the way they're talking about these topics. So Ebola vaccines and Zika are a couple other examples, and you can see different colors in the map. And I've circled in pink. Guess who that is? That's us, who we might consider the health experts, and we have our own echo chamber. So we're really good at talking to each other because we share our same biases, right? But when it comes to reaching our communities, this is just what you two were talking about, when it comes to reaching our communities, reaching the right influencers, reaching that broader community with our message, we have to kind of rethink the narrative around that message, or the people we're sharing it with, because right now our science-based, our evidence-based information is just echoing among ourselves. So this brings me to wrap up that we're moving from what has been called the age of information, which is when the internet came about and everyone had access to all this information in ways that we've never had before. It was the age of information. Well, now we're really moving into the age of reputation. So, and what this researcher, I love these, is she's saying that what a mature citizen in the digital age needs to be competent at is not spotting and confirming good or valid information, but instead she should be competent at reconstructing the reputational path of that piece of information, evaluating the intent behind the message and the intent of the person who circulated it, and figuring out the agendas of those authorities who are giving that piece of information credibility. So see the difference? It really becomes, so when I showed you how that narrative changed and influenced a city, if that city had been able to reconstruct the reputational path and get back to that original source, the outcome may have been different. So this is changing our responsibility in how we reach patients, communities, and work with them, is we're really training them to ask these questions. So where does the information come from? Does the source have a good reputation? Now, good can be subjective, and that's where we need to build that trust and bring in that expert recommendation of what a good source of information really means. It may not be YouTube. It may be a different source of information, right? Who are the authorities who believe this information? That can be a powerful influence for the overall reputation of that information. And what are my reasons for deferring to those authorities? So that helps us better understand the identity of our communities and our patients and the kinds of authorities that they consider to be the experts in a given topic. So when you look at those big maps, we're just one small cluster in those maps. There are information authorities in every one of those communities, those digital communities that we aren't a voice in. So we really want to start understanding these networks more broadly that are influencing our communities. So in the reputational age, our critical appraisal should be directed not at the content of the information, but rather at the social network of relationships that have shaped that content and give it a certain deserved or undeserved rank. So this really goes back to, these are all very social interactions. We're social humans, right? And so it's about who is linking to who and who is sharing what. And if a person brings in a piece of information that they got from their peer group online on a social network, they're going to give it a certain amount of credibility despite the content in that message. So that's really what the age of reputation is all about. And so this is what we mean, the social networks are the new neighborhoods. So we live in a public health neighborhood, so we talk about community water fluoridation in a certain way, or vaccines, or the Zika outbreak. But there are many other neighborhoods who have their own authorities who are talking about these in very different ways, and sometimes in harmful ways. And so this is kind of what we're trying to do, is how do we infiltrate? How do we get out of our own public health echo chamber and infiltrate and become neighbors with others outside of our own communities? So we're really moving from the previous form of health communication. How do we get our evidence-based information to our audiences? That's what most of us have been working on, is getting the evidence to the communities. But now, how do we get our audiences to share our evidence-based information? And that's a totally different communication approach. So before, it's just communicating to, or doing something to, and now it's a with. We are all working together. So I need you to engage with my information and be so convinced that you're going to share it with your peers as well, and we can get out of our own echo chambers. So that is my last slide, and I'm going to put my email up. So for anything I've talked about, please take my email since I won't be able to stay today.